Hello, everyone, and welcome to tonight's webinar. It is great to see such a big audience out there. This is Farood Hakim, and we are going to talk about elevating our games. In particular, we're going to spend a bit of time talking about composite materials, composite technology, and delivery. Before I dig into this, I wanted to take a second and just apologize to the audience. After however long the pandemic has been running, 2.5, going on 3 years now, I finally pulled a positive test for COVID just 3 days ago. So I am a little under the weather, and I'm sure I don't sound great with my sinuses, but I am coming from you right from the middle of my 5 days of isolation. And so I may not sound great, but I can't be more excited about spending some time with the group out there. Anyhow, as we jump into this, I always like to start by telling the audience a little bit about myself so they have a good idea of my background. I basically wear 3 hats, biggest of which is that I'm a dental educator. Have been doing this since graduation in 1991, and progressively over the years expanded my role to the point where I am full-time faculty at Pacific. That being said, it's also important to understand that I am in private practice, have been since 1991, and have a strong presence in a for-profit private practice with actually a couple locations. And so I am wet-fingered, and I have to live, breathe, and eat this stuff that we talk about daily. So you're not just hearing from a type it on or a textbook jockey. Finally, what brings me to you guys today is I've been fortunate enough to work as a speaker, as a KOL, with a lot of the dental industry out there, a lot of great companies, much like Voco, who we're working with today, being able to evaluate their products, consult on manufacturing, be a beta site. And so it gives me some great exposure, work with some other great colleagues that do the same. And so hopefully my message is not one of any kind of bias or market-driven approach, but one of kind of testing and standards. So with that said, here's a good website to visit. Here's some of the pictures of my colleagues on Catapult. If you ever get it, undoubtedly, a lot of you have already had a chance to see some of these big names, but if you haven't, definitely attend any of their lectures live or digital. I stand behind all of them, and I think they have a great message. We also do a lot more on Catapult, so it's worth visiting the website and looking at our various ways of kind of layered learning that we've put together there. That said, a big thank you again for Voco. They've been a great partner forever, and while they help support this, a big kind of kudos to the company because they're always delivering great products to the marketplace, as well as putting their money where their mouth is with regards to supporting education and CE like this. That said, jumping into the course, I'll start with this question. Who out there really thinks we need another composite course? I feel like that dead horse has been beaten for a lot of years now, but honestly, in my opinion, I think we absolutely need it. First and foremost, these direct, basic resin restorations, these simple fillings that we do are the staple or the backbone of contemporary restorative practice. And while they are very commonplace and we rely on them daily, they are not without the challenges. They continue to be some of the most challenging things that we do, whether it comes to placement, being efficient while placing them, how they fit into our economics, how long they last, so they survive in the mouth, issues with teeth having sensitivity after fillings are placed, the age-old problem of contacts, contour, making them look good, having nice flossable contacts that don't pack food, aesthetics, the list goes on and on. So there's lots of challenges. And at the same time, there's new products that are literally emerging daily. Every single day you open up one of the dental tabloids or magazines, and you will see a new composite promising the greatest and the best. And so it's important for folks out there to stay ahead of this stuff and really kind of be able to separate out the science from marketing and see what they're dealing with. Whenever I lecture, I always like to start with this framework, because if you remember, I'm in private practice, but because I'm a full-time educator, I'm only in private practice a day and a half a week, which means that efficiency and productivity is incredibly important to me. In that day and a half week, I have to do the best I can to mitigate redos, errors, having to retreat things a second or a third time without it being a chargeable procedure. This is the daily overhead rate in the average practice in the US. It's about $390 an hour, which equals $6.50 a minute. That's what it costs for us to break even. In fact, we're in California. When I add the numbers for our office, we're probably somewhere in the mid 400s. And of course, that figure was pre-pandemic. And after the pandemic, a lot of things have changed. Certainly costs has gone up, labor costs have gone up, materials, PPE, things like that have gone up. We're dealing with huge inflationary crisis right now. Certainly early on, we had to reduce patient flow, reduce volume, increase gapping, not work on multiple patients at a time, having patients hotel outside in their cars, call them up one at a time, all the things that we needed to do to mitigate the aerosols and all the things we were concerned about. So I'm sure our overhead per hour is probably higher than this. This is a figure that we came up with a couple of years ago. So at the end of the day, speed, efficiency, predictability, having great outcomes, and reducing redos has never been more imperative. And today's composites are a far cry from what I was trained under. So if we look back at the last few generations, I'm going to say, but especially since I teach at school and I know kind of how docs are trained, I'm going to say anybody trained in the 2000s, they basically grew up in the white or aesthetic age of dentistry. This is where tooth-colored restorations, ceramics, things like that really got a foothold, and there was a huge emphasis on aesthetics. And so this is near and dear to what they learn. It's right in the middle of their lane, and they know that it's important to keep up with new materials, but they're very comfortable with this. Go back a generation or two, I graduated in 91, and I would call our age the silver age of dentistry. When I graduated, we practiced an awful lot with amalgams, and we were exposed to composites, but they were kind of the quote unquote specialty material that we use in the front of the mouth. And we heard a lot of warnings about how they are not as predictable, not as lasting, but it's just what's necessary to deliver something aesthetic. Go back another decade before that, and folks before me basically grew up in the golden age of dentistry, knowing that gold indirect restorations were probably the best materials out there, and again, took meticulous skill to deliver them. We get very nice restorations using gold. It's a different era now. So the latter two groups, we had to first really learn about composites, understand the material science, learn to trust the materials, and then finally learn how to put them in play. How do we place them? This whole time, while we're trying to learn this on the back end, materials keep changing constantly. I'll share this small little report with you. It's a report from Delta Dental. Anybody that's insurance driven in the US knows Delta is the biggest insurance provider in the country. And this is their report. This is obviously not a peer-reviewed or scientific publication, but it's an accurate report formed based on their kind of actuarial process that basically says, hey, we obviously reimburse a lot of doctors. We have a lot of repetition. And so in our archives, when we look back, we can gauge that an average amalgam seems to last about 11 years. That means that a patient was paid, or a doctor or patient was paid for benefit on a tooth with an amalgam 11 years ago before that same tooth was rebuilt for a new amalgam. When they flipped the switch and looked at composites, you can see that the average age of a composite before failure, or at least perceived failure, conceived failure, and redo was 4.8, so basically 5 years. So if we just look at this data, we could probably conclude that, hey, amalgams last twice as much as composites. And a lot of my old school faculty, when I was getting first trained, would certainly echo this concept. Yeah, of course, amalgams last much longer. Composites are just a necessary evil. Well, I know we've certainly come a long ways away from that, but when we look at this data, how are we supposed to reconcile these findings? What are the conclusions we can reach? I will say the foundation for any lasting composite is obviously the adhesive layer, and I am fully immersed in the composite dentistry era. I feel like composites can last as long as any restorative material we've ever had if they're done right. And that if is a big if. They are an incredibly technique sensitive material, and that accounts for a lot of that range, because we've certainly seen composites that are well placed, that are in the mouth 10, 15, 20 years later. And we've seen composites where something goes wrong and there's a catastrophic failure within a year or two. Amalgam didn't quite have that technique sensitivity. an amalgam could be placed, and if it was done to perfect standards and A level, it would last a long time. And if it was done to C standards, it generally would still last a long time. It would kind of corrode and expand and self-seal, and it may have not looked as nice, but you still got a decent work life out of it. And that's what's different about composites. And of course, the foundation of that's based on the adhesive layer, the bonding agent, how that's applied. I've done separate webinars on Viva just about adhesion, and that could be an all-day or a 2-day study. So we can't jump into the science of that, but it's always nice to have these general guidelines. What I would say is that to kind of be in the mix with what the contemporary approach is, it's basically pretty accepted the phosphoric acid using that blue gel, usually it's blue, etchant that we use to prepare enamel is considered the gold standard. That doesn't mean we can't bond to enamel with self-etching primers. It just means we're not going to get as predictable or a lasting bond because we just can't get the same etch patterns. So when you have enamel, we want to be able to pull out phosphoric acid. That being said, I grew up in the era of total etch, where we would etch enamel and deton. And right now, the self-etching primers seem to yield, that's at least what our independent studies show, the highest and most stable bonds in deton. And at the same time, they tend to reduce the incidences of postoperative sensitivity. The highest bonds of deton we test are usually very specific 2-component bonding systems tested, for sheer bond strength. And then when we look at convenience, certain universal adhesives tend to give us not the highest, but pretty darn good bond strengths. And they do introduce a lot of conveniences as far as inventory and simplicity. So at the end of the day, poor bonds equal lost dollars. If I don't have a good bond, I'm going to have a patient that comes in, they're going to have sensitivity. I have to do adjustments to accommodate for that, or they're going to have recurrent decay or loss of a restoration. And we know that we're redoing this, and in practice, a day and a half a week, I just can't afford to be redoing restorations. They have to come out the way that I anticipate they will and last for a long time. One of the great universal adhesives out there that I've used for a number of years is Futura Bond from Boco, but it's important for you to be comfortable with your adhesive, trust the science behind it, and make sure that it's one that not only works well in your hands, but has good third-party validation to it. Now, if we ask a group of KOLs and people that are in the know, quote unquote, ask them what the best way is to manage that etching or conditioning, by and large, the majority are going to say you want to employ a selective etch process. And this is what we're talking about. If we have only enamel as a substrate, well, then phosphoric acid does that. And that's what you see in the lower right. If we have only deton as a substrate, then we're going to use just the self-etching primers, for example, the 6th generation through the universals. However, a lot of the work we do, and especially when we're talking about direct restorations and just meat and potatoes dentistry, posterior composites, is going to be a mixed substrate. The little picture on the lower left actually shows preparation for bonding in an onlay. This onlay has enamel around the edges as the margins, and of course a big lump of deton in the middle. So this is what we mean by selective etching, is I would lay down phosphoric acid on the enamel for 20 to 25 seconds, wash it away, and then go and apply my self-etching primer and adhesive, whether it's a 6th generation, which is 2-step, or a universal, which is a 1-component material, scrub that in for the prescribed amount of time, and I'm ready to go. So the next biggest question I always get when I'm doing classes is, what composite should I use? And that's kind of a loaded question, and it has a complicated answer. I'm never going to rattle off a name. It's never intended to be an infomercial. I'm always going to help the person asking the question to kind of look at their own dentistry and see what they do and what their challenges are. I can tell you that I can't personally practice at my highest potential without having a variety of composites in practice. And I know that sounds complicated, and the impact isn't for folks to go out there and say, okay, for me to do this, boy, I got to inventory 7, 8, 10 different types of composites. And not all the case. I know there's a lot to be said about reducing inventory and making sure everybody's trained on the same materials in an office, especially if there's multiple providers in an office. What I'm saying is that viscosity is the key, and we want to have at least a few viscosities available regardless of the brand name. Now, I certainly have my favorites and preferences. You'll hear about a few of them today. But what I mean is that I don't think we can practice at our highest capabilities without being able to modulate the viscosity of the composite. Now, composite materials have advanced tremendously since I graduated, 30 plus years ago, and they're continuing to evolve and advance based on a number of things that the manufacturers figured out through their kind of painstaking R&D processes, but none more so than modulating filler. So most of the advancements in composite technology come through this filler modulation. And so we'll talk a little bit about the evolution of this. Early on when we graduated, or probably before I graduated in the 80s, basically people fell into two camps. If they did a lot of posterior restorations and they were pioneers in doing composites, they used what was a macrofill class of products. These were those early generations that were strong enough because they had large particle sizes of glass within them that could hold up under load and occlusion for posterior restorations or for buildups. Then folks that needed to address aesthetic issues in the front used microfills. These weren't as strong, but they handled differently. They polished better, stained less. And so really early adopters, to be able to practice composite dentistry in the front and in the back of the mouth, they actually had to inventory two different types of composites to be able to deliver, at best reasonable results. And even then, it was not perfect. So here's, just in a cartoon format, here's what a microfill would look like. You can see lots of smaller particles. Here's a macrofill would look like. A macrofill, by having these bigger glass fillers, was less likely to collapse or fail under load. And so early on, the thought was, well, how do we start to get the best of both worlds? Can we make a composite that's a hybrid where we reduce the actual filler resin, which can be evil, that's what leads to some shrinkage, by mixing up bigger rocks and smaller pebbles in there. And by doing this, we can eliminate some of the resin and get some of the polishability and get some of the strength. And so early hybrid composites were the initial attempt at launching something into the market that could suffice both the needs for the front and the back of the mouth. And like almost anything that you try to combine two things early on without a lot of kind of science behind it, it was kind of a jack of all trades, but master of none. They had very limited results. But then they didn't stop. They kept working on this. And so they started to modulate particle size. And you can see on the next box, the next level of products were called the microhybrids, where they started to get microscopic bits of glass and larger fillers and modulate across multiple sizes. And this is kind of the boulders, rocks, pebbles, sand theory, where the more we fill a material, reduce the resin, the more we can kind of get the benefits of all the different characteristics. And this has advanced so much enough to where now the primary emphasis is to use nano-sized particles, which are extremely small. Now they can be clustered and sintered together to form a variety of different backbones for composites. And really the nanotechnology is what is a hallmark of the most modern composites out there. To give you an idea of what that means, if you look at some of these microscopic views here, a dust mite might be 200 microns. A human hair might measure 60 to 120 microns across the width of it. Red blood cells are 2 to 5 microns. When we're talking about nanoparticles, we're talking 20 nanomicrons. So these are fractionally smaller, extremely small particles, but they can be, like I said, merged and sintered and clustered together to really help us deliver composites that have these characteristics, ones that are very polishable. Not only how well they can polish, but how long they can retain that polish. By eliminating a lot of the excess resin, we can reduce shrinkage. And for anybody that's been doing composite dentistry for decades, we know that the biggest issue with composites was that they shrank, and that caused shrinkage stress, which then caused a number of things, from stresses to the tooth or marginal fracture or gapping. And so it's always been an issue trying to mitigate that shrinkage. Now, contemporary composites, any composite that's worth its weight will have the shrinkage down to below 2%. So I'm not going to say it's not an issue anymore. We always want to mitigate shrinkage and think about it, be thoughtful about it as we place composites within a restoration. But that was the whole reason why we added composites and layers prior to the bulk fill generation, was because we were trying to mitigate that shrinkage. And of course, how that filler is incorporated has to do with handling. And if you ask most doctors, they might have 3 reasons why they choose a composite, but almost always their first choice has to do with handling. Some people like a stiffer composite that's stackable. Some people like a creamier, more buttery composite. Then they'll go to aesthetics. Can the composite deliver the aesthetics that they want? And finally, they'll go to how well does it polish and does it attract stain over time, and longevity, and how it resists wear and so on. So all these things are very important, and so much of it comes down to that filler management. So at the end of the day, an optimal restorative, our goal is to basically get it to behave as much as possible like a tooth, have it have the natural fluorescence, thermal behavior, and elasticity of a tooth. Now, some of the examples of well-rated microhybrids out there are, and I'm sorry, not microhybrids, but nanohybrids out there are Genial, for example, from GC America, Filtech from 3M, Mosaic from Ultradent, Harmonize from Kerr. These are undoubtedly names that you guys recognize. I'm going to spend a little time showing some restorations that I've done with Grandioso from Voco, which has been one of my go-to materials now in practice for a number of years. But I will say this: if you understand the concepts behind adhesion and bonding, and if you are using a good contemporary composite, and I'll say a little bit more about that, a lot of this becomes a preference of the practitioner. Given a good composite, if I can control the environment, have good isolation, I have a great adhesive layer, and I have good materials, I can pretty much make a nice restoration with almost any contemporary composite. What happens, unfortunately, for docs out there is we get a little complacent with staying up to date with materials. And so we start with a certain composite. It may have been the best of the previous generation. If I go back 10 or 12 years, there were certainly composites that I loved then as well. And they were the latest that material science had to offer. And we put them on auto order, and we think nothing has changed. And our assistants will routinely order refills, and we just plug along doing really nice restorations. Meanwhile, the materials evolve all the time, and more issues with composites continue to get addressed. And quite frankly, manufacturers have better materials out there now. So it's really important to have more frequent review of materials. And so when I say a contemporary composite, I'm going to say if you're not using a composite that has that nanofiller technology, which has really been around for a decade and a half, you are dealing with a stack deck. You're not using what the best that science has to offer. So Grandioso was one of the first nanohybrid composites out there. It comes both in compules and syringes, depending on your preference. A fairly simplified shade guide, not so complicated where you have to inventory 30 shades, because we all know what happens. The less frequent shades sit and expire, and we keep reordering the ones that we most frequently use, for example, the A2. So if you can find a composite that delivers the aesthetics that you want within a more limited shade batch, I think you're always going to be ahead inventory-wise. And even then, within the nano world, not all composites are created equal. Depending on how these components are put together, you'll find manufacturers that are able to get their composites more filled, both by weight and volume. And what really matters is volume. We can artificially inflate the weight by playing some tricks with heavy glass, but the more filled the composite is by volume, the less the resin, and so the better the final outcome. We did mention how small nanoparticles are. And so while they are a solid, when they are so tiny and small, they basically have the ability to minimally diffract rays of light. And how we modulate those nanofillers exactly does what we see our composites are intended to do, meaning our more translucent composites that are more designed to replicate enamel allow light to go through, versus our more opacious composites that are designed to replicate dentin mask out the light. And this is how manufacturers will make their body composites, maybe opacious, very opaque composites to block out stain, more traditional dentin shades. some body composites that are kind of in between, where they could act both as enamel or indentin, or highly translucent composites that let a lot of light go through. And this is how we can deliver three-dimensional aesthetics when it's called for. Now, do I always use multiple translucencies? A lot of times I'm using fairly standardized body or enamel composites when I'm delivering final restorations in the back. But we know that sometimes we have cases where aesthetics is crucial, and understanding how to get to that aesthetics is really important. So let's look a little bit at some clinical cases, and you'll see almost all the cases I do are always gonna, I always have a big emphasis on isolation. This patient is wearing an isolite and an Optigate to keep the lips out of the way. I'm either gonna work with an isolite or a rubber dam always, and the science just vets that out. If we have any kind of moisture contamination, quality of our adhesive layer drops. This patient has an old amalgam on their bicuspid here that my cursor is on, and it's got some recurrent decay, a little fracture line, and some mesial decay. So we're going to take that out. Now, one of the great things with composite dentistry is, unlike amalgam dentistry, we don't have to blow out our contacts and reduce a certain amount of not just diseased tooth, but healthy tooth to match the material, meaning we don't have to follow kind of the GV Black principles of preparation. With composite dentistry, we get to just remove the disease. So in this case, I'm not guaranteed that I need to break contacts. I know that this carious lesion here is not terribly wide. So a lot of times I'll use these little fender wedges or wedge guards to go in between. This is a straight up and down picture, so it might be hard to see, but there's a thin metal shim connected to this wedge, which helps me get very close to that adjacent tooth, kind of bump up against the metal shim without actually scarring or nicking the tooth. And you can see how I really haven't broken contact significantly. In fact, if I take this wedge out, the lingual wall is probably in contact with the tooth. The buccal wall might have 1/8 of a millimeter clearance. There might be even some areas where the line angles are, or the exit angles are not 90 degrees. They might be slightly undermined. But with composites bonding to the dentin and the enamel, basically it makes the replacement dentin for that enamel. So we're not as worried about undermined enamel like you would be in an amalgam where there's no adhesion. So I can preserve this tooth structure. The more this patient gets to keep their natural tooth structure, the better. And then especially on this mesial line angle, now I don't have to worry about aesthetics. If somebody's got a big smile and I blow out this contact unnecessarily, then my composite has to match. Otherwise, there's going to be a little stripe of a different color there unless I've spent the time to get that exactly matching. So once the amalgam is gone, once the disease is gone, we're ready to restore this. Again, this is a Triodent system that I use, and I'll talk a little bit about it. It's one of my favorite 3D band and ring systems out there. The wedge and the wedge guard were made by the same company. So I have that placed in the mouth with a sectional band that we'll go over the details on. These are invaluable tools to me, but I'll share some nuances about how to get the best out of those. Adhesive layer is done, and now you can see the base of this restoration has what I term a bulk fill flowable composite. This is really critical, and I'm sure it's not a foreign concept to anybody out there listening, that we generally want to line our posterior composite restorations with the flowable. Now, some people only reserve that for the gingival box. I basically use it almost everywhere. I'm basically using the flowable because of its ability to adapt to that adhesed layer, to the adhesive layer. If I try to pack body composite to the gingival floor, and especially if there's irregular nuances or 90-degree angles, as I plug in a composite into these areas, there's always a chance of my instrument tugging back on the body composite, lifting up, getting voids. And so I'd rather have 0 voids at my base layer or adhesive layer. So I will fill the entire gingival and pulpal aspect of this with a flowable and drag that up partially into the dentin. That way I'm confident that I have perfect adaptation 360 degrees around my restoration. Now, if I don't have a bulk fill flowable, I'm never going to make that flowable more than 0.5 millimeter thick. Often it's only 1/4 millimeter thick. However, if I'm using a bulk fill flowable, and in this case it was extra base from Voco, then I know those are designed to mitigate the shrinkage And so I can use that and afford to bulk that up a little bit more. Manufacturer says, Voco says up to 4 millimeters. I always take that with a grain of salt, and I rarely use it past 3 millimeters. But what that does is it fills up the bottom half of my box, which means that I don't have to go and painstakingly layer additional layers of composite. I can build up my full occlusal and marginal ridge contour with 1 or 2 layers, which means that I'm much faster with my final restorative outcome. And here it is after 2 layers, a little bit more of a dentin layer, and then finally an enamel layered composite. This is not some fancy composite I spent hours on with 5 different shades of materials and opacities and put Pitt and Fisher stain in there. And you can see arguably that it looks very much like a natural tooth. It was delivered in all of 20 minutes or so. And we always snap a picture of this. And routinely, I will do this. I'll take a before picture with the internal camera, have it up on the screen blown up so the patient sees what we're doing with it. Then I take a picture with the prep open so they can see all the nasty stuff that I found. And that's always great for justification for them. They don't know if they're not having any pain that there was really a cavity or not. So it's a way to build rapport and trust. They see that, oh yeah, there's obviously some ugly stuff in there and the doctor's taking it out. And then a final picture. And anytime a patient sees that before and after, I don't care how simple the aesthetics are here, their eyes will go to this, and they start to ask, okay, when can we do the rest of the teeth? So I think really good aesthetic dentistry tends to lead to more aesthetic dentistry as well. Let's look at another case and some earlier detection. Here is a patient that has basically glorified fissurotomy preps, areas that are mainly within enamel, maybe a couple of spots of those stains dip down into the dentin. But through a bite wing, we knew that there was proximal decay. And we knew that it was starting to get through the dentin. It was, or get through the enamel into the dentin. These were D1 lesions. And the patient was not at a point where no matter how much we emphasized good oral hygiene and putting him onto camber products, they had begun to have certain things get bigger in other quadrants of their mouth. So it was one that we had to intervene. So there are the preps. Again, the only reason that I have broken contacts here is because the decalcification from that zone of caries extended to that. If it wasn't past that, I wouldn't even absolutely have to break contact. But I'm a firm believer in removing all compromised or decalcified enamel so that my bond, my outer bond, which is my hermetic seal, is to the best quality enamel possible. Now, if you have a good ring system like this Trident system, you're always going to know you have the confidence in the physics of it to separate enough for 2 contacts. If you're not confident about that, don't push the envelope. Sometimes we have to restore one and the other. Remember, when we're trying to restore 2 contacts, this ring has to soften up the PDL and separate both of these teeth enough to make up for the thickness of 2 sectional bands, not 1. And if the boxes aren't exactly the same, sometimes one band will collapse into the other. So I don't always restore 2 contacts back to back at the same time, but just over time, out of kind of experience, I know when I can get away with it and when it's wiser for me to just do one at a time and to be done with it that way. Because remember, I hate redos. And the last thing I want is a patient coming back a week later saying, yeah, your filling looked great. Everything turned out awesome, except this one keeps packing food, because then I'm digging it out, redoing it for free. It's not good for the economics of my practice. It's not good for patient confidence. So again, this is a very low traditional flowable composite, very light viscosity. I get it to all the nooks and crannies. This is a heavier flow composite. In fact, it's called Heavy Flow from Voco. I use that to fill the occlusal anatomy. This is that composite that's kind of the marriage and viscosity between a body composite and a flowable composite, because there could be some light occlusal load, even though it's at the very depths of the pit and fissures. I know with that microscopic fissurotomy prep that I had, there is no way that I can butter in body composite without having voids. I know that I won't be able to drive that into those V-shaped fissurotomy preps. So I'd rather have a flowable composite that can hold up to some occlusion. And then, of course, the marginal ridge area, I'm going to build up with a traditional final layered capping composite and have a good solid snap and a contact. So I think you're getting the sense of how important viscosity modulation is. especially in today's world when we have more and more MID dentistry or minimally invasive dentistry. It's beneficial to retain as much tooth structure as possible. But one of the things that G.V. Black talked about was access form. And with amalgams, we needed big blown out restorations because A, we needed to have our amalgam restorations be thick enough not to break. They had to be at least 1.5 millimeters thick. But we also needed access form so we could get our different instruments in there, amalgam carriers, condensers, things like that. With composite dentistry, as long as you can get something that has a flowability to it, you can drip it into the cavity prep and make sure it adapts to the gingival wall, and you won't have to pack it in. So there's far less limitations that necessitate us over prepping teeth, and that's a big advantage as we get to help people keep more of their natural tooth intact. Here's another case I recently did with Grandioso just for a publication. Typical, we see amalgam with failing margins. There it is, all cleaned out. I'm going to show this every step of the way with the patients. Again, mixed substrate. So here's an example of what we talk about with selective etching. That's ultra etch from Ultradent around the edges of it. And of course, apply my adhesive layer. Now, this isn't a first molar. I don't know if this patient really would have been able to tell the difference, but I don't love to see it. So when there's that dark tattooed area from the old amalgam, you can use a little bit of opacious flowable composite. This is just an opaque shade of Grandioso Flow. And what that does is it masks out that amalgam tattoo. And so it doesn't shine through as gray. You can see how dark it was before that. And so your final restoration has a chance of looking, a little bit more true to life. And so there's the final restoration brought up to polish. So another trick to manipulating viscosity, in addition to having kind of an array of flowable composites in the office, I do use quite a bit of temperature modulation with my composites. And so Voco has a great product called their Caps Warmer. Another company is Calcet that has a composite warming device. These very simple, inexpensive things that you plug in. They have controlled settings to where you can heat up things to kind of a lower, moderate, or higher level heat. You can load these with your various ampules, different colors. You can put instruments in them. You can have a gun preloaded. In fact, these are great to put anesthetic cartridges in at the low setting, which is approaching 100 degrees Fahrenheit, which is basically body temperature. You'll give some of the most painless injections possible, especially when you go into the office Monday morning and your anesthetic has been sitting over a cold weekend and you're trying to push it into somebody when it's maybe 60 degrees, the anesthetic, and their body's 98.6. It's a very useful thing to have, but I often will work with more warm composite, and there is endless literature out there about the benefits of warm composite in all aspects, but the biggest benefit is handling and flowability and how you can get it into the right places the right way. Finally, you guys saw some of the tools that I've been using to deliver this dentistry, and it goes without saying, we can't deliver appropriate posterior class 2 composites without having the right band and ring system. The one that you saw pictured in those slides was a Triodent system formed out of New Zealand. Dentsply and Ultradent sell that product here in the United States. Basically, it comes with 2 different size rings, kind of a bicuspid and molar ring, where the tines are a little bit closer together. But the magic, besides these rings having a V shape that sits around the wedge and sits low on the tooth, a big part of the magic is in the shape of the sectional band. It's got all these cool little holes that you can grab and pull out of, because the sign of a good contact is one that you can't pull the band out of, but also how it has a negative curve for the gingival aspect and a positive convex curve for the marginal ridge. And we'll talk a little bit more about that. But here's the forceps that help you stretch the band out. You'll notice there's 2 little notches here. So as your bands lose a little bit of their flex, you can cinch them down again and get a few more miles out of them. And then they're very neat pin tweezers, which has a little bird beaker prong that helps you hold the wedges or the bands and articulate them in any different way, so you can enter from the buccal or the lingual upper or lower. Just useful tools that the developer came up with, which just makes daily life to life a lot easier for me. Now, here's the big thing with composite contacts and was a learning curve for me, who graduated kind of in the amalgam era. We knew that when we did amalgam contacts, we could condense kind of the heck out of that amalgam, and we would wedge the teeth apart, heavy pressure with our strong wooden wedges. And that's how we softened the PDL and expanded the tooth. Then we would further condense the amalgam, which is compressible or condensable. Then when we took our band out and the wedge out, those would bounce back, and we created enough positive contour there that the thickness of our Toffenmeyer would not lead to an open contact. It's actually exactly the opposite with composites. Even our stiffer composites, while they may be called quote unquote packable, cannot displace a tooth. They cannot condense to the point where you make up a contact. And the wedges, specifically the ones I use, aren't designed to separate the teeth a whole lot. In fact, I'll talk a little bit about the wedges that I use, which go along with the system. The separation that really comes from the ring. That's why that ring system is very important. You can see here in this picture, the photo was taken without the band in. It's literally teeth before and after the ring's in place, and you can see that separation. That's where the thickness is made up for the thickness of that sectional band. So it's important to have a band and ring system that has a variety of band heights. And yes, composite dentistry is complex. Unlike the days where we just had one size Toffenmeyer, those days are gone. With composite dentistry, you have to have a few more tools in the tackle box. And so I'll always do my prep. I won't just house one or two band sizes. At the very minimum, I have about 4. Now there's 2 that I use the most often, but you never know. You're going to have a restoration that goes clear down the root structure. You're going to need this double curved band. You have pedo teeth or very shallow preparations. You might use the 4-5. A lot of times the averages are 5-5s. Once I prepared my box, I will see how deep that box is. I will select the band that comes up right up to the exact height of the marginal ridge. Yes, I can get a 6-5 band to fit into a 4-5 preparation, but because the gingival aspect has nowhere to go, it will climb straight up here, which will lead to me making a much taller marginal ridge with the curve in the wrong spot, not where it's anatomical. And then when I remove everything and check the bite, there'll be a high spot here. And as I grind that high spot down with my burr, I'll destroy any natural anatomy that I created, and I'll no longer have my marginal ridge curve. It'll be a flat contact that will tear or shred floss. So it's very critical to seat the band and make sure that that curve right at the marginal ridge is right at the correct height, matching that adjacent tooth. The other thing about these wedges, like I said, they're not designed for significant separation. These trio wedges have kind of a double hourglass design, and I primarily use the purple and the pink. If you look underneath, they're hollow. They're hollow so they don't traumatize the papilla. They actually straddle and sit low over the papilla. And as they go through the contact, the second hourglass component spreads out. So both the buccal and the lingual aspect of that band gingivally are well sealed against the tooth. So they mitigate a lot of excess flash. Because unlike amalgams that we can go and carve away the flash, with composites, once they're set, they're set. And trying to remove flash, especially at or below the gum line, is a butcher job. You're basically getting burrs in there, hurting the patient, cutting things up, and you never quite get all of it off. So it's always nice to have a perfect seal at the bottom of your band with no space, and these wedges go a long ways towards doing that. We talked about modulating viscosity, and I'll show you some other types of restorations that I do, but unfortunately, I house all these products. So for example, I use a light flow material, and there's lots of good flowables out there. I happen to like the Voco products a lot. So they make a light flow, very runny. If you have some very kind of precise pit and fissure anatomy that you have to fill, or you're going to put a small increment down into the bottom of an MID preparation, this light flow does the trick. Their standard flow is right in the middle, kind of fits the bill for a lot of basic indications. And this is the heavy flow that I talked about. This is where I know that there's going to be some burden of occlusion. For example, erosion pits on cusp tips, which are called class 6 restorations. It's very hard for me to get a body composite there. But this heavy flow, you'll see it can mousse up like soft serve ice cream. So it's more filled. And so it's going to withstand occlusion a different way. And of course, this is the bulk fill flowable product that I talked about to rapid fill the bottom half of the box. One of the important things I think for everybody to consider is radiopacity. You want to select a flowable composite that is high on the radiopacity scale so that you don't see that kind of unwanted image on bite wings. And we've all seen this where you see your body composite and below that you see something that is a little questionable. You don't know if it's a void, you don't know if it's new decay, you don't know if it's a thicker layer of adhesive that wasn't thinned out. You want to make sure you have a composite that's at least north of 300 on the opacity spectrum, and even their flowables do fit the bill here. And so that's another reason why I gravitate towards these products. So very quickly, we can talk a little bit about class 5s as well, because viscosity comes into play quite a bit. If you ask people, should you replace these class 5s, they will each give you a different answer. There's always a question of, what is the origin? It's obvious when it's caries, but we've been calling them quote unquote abfraction lesions. And what does that really mean? This was something described by Grippo years and years ago. Now the more contemporary term is non-carious cervical lesions. Of course, these are the ones without decay or caries. Dr. Abramson has shown research discussing these being the result of sometimes dentifrice abrasion using not only toothbrushing, but a very abrasive toothpaste. There's certain ones that we know erosion plays a big hand in, and we're talking about acids, intrinsic and extrinsic. We know there's some link to sleep and parafunction when it comes to apnea. And so diet, reflux, people with dry mouths that don't have the buffering capacity, this again can make for an all-day lecture about the science and the etiology behind class 5s. But in a short webinar, we can at least talk about some of the best methods of restoring these and how to restore them. Here's a couple of useful bits of literature that anybody that's interested can look up and kind of get some of the latest on what we think about with class 5s. But the big question, should we restore these? And often the answer is depends on who you ask and their luck with composites. But in my opinion, I think we should almost always restore these. I would say always, except that I know almost and never, or always and never are terms that probably don't belong in dentistry. So I'm going to say I restore these 99% of the time. We can look at them, look at the shape of them. You can see this person has a few different ones based on the way they're clefted, based on if they're shiny or matted and finish. We can make some guesses to the etiology. But however they got there, that's not how teeth start up, right? These are not natural progression. This is a disease process. And our goal is to, in our practice at least, is to treat disease. So we don't monitor these. I choose to treat disease and ideally just monitor a healthy mouth. Now, a lot of folks will say, yeah, they're not hurting the patient. Why should I treat them? Well, if you're watching the smaller ones get bigger and bigger and bigger until they become more vulnerable and you have catastrophic failure of some sort, then basically you're chaperoning disease. Now, if we restore them, then maybe they won't look like this. But you can look at any mouth and you can see that there's starter sets that turn into these later. How would you like it if you go to your cardiologist and he or she says that, hey, some of your vessels around your heart have some minor plaque in them and they're about 20% occluded. I'm going to monitor these, but I think I'll treat them when they're 60% clogged. It's funny, but we would never accept that. So why should we do the same thing for our patients? Why should we allow their disease to progress? Well, often these are right in the front window too. Now, these are posteriors, but a lot of times it affects patients' sense of well-being with respect to their aesthetics. They don't like these long teeth with the yellow or darker lesions. And if they have a wide smile and a bigger aesthetic zone, they don't like to see these lesions either. And so they really appreciate the restorative aspects. So a lot of people don't restore them for good reason, because they see things turn out like this. either they fall out or you start to see a little bit of stain. And in short order, you see heavier stain and eventually catastrophic failure or decay. And they say, hey, I don't believe in dentin bonding. I don't trust it. I always see these fail. And so in that case, if that's the outcome that you're accustomed to, then you're right. Because one of the axioms we took was to do no harm, make the patient better. And if our restorations are starting to look like this very quickly, then we're not doing something right. But that's not something that can't be overcome. With the right adhesive, with the right technique, we should be able to restore these pretty effectively and get very long-lasting restorations there. So when you see composites like this, you have to figure out what's going on. Is it the material? Is it the adhesive layer? Is it the technique that's used? And it often is a combination of all of the above. I almost exclusively restore my composites with flowable, and that often will surprise people. But what I get out of that is very precise placement. I get composite that's strong enough to withhold load demands, because remember, these aren't under occlusal load. But they have a better flexural modulus, much closer to that of dentin. And if there is an abfractive or vibrational component to these, you want a composite that's not more rigid than the tooth, that will bend with the tooth if there are flexural forces at the neck of the tooth. But we know that flowables by nature are less filled. That's how manufacturers get them to be flowable. And so what about filling a very large class 5 with flowable? How do I mitigate that shrinkage? And we'll talk about how we decouple walls to basically make the shrinkage a moot point, a non-consideration. They help me do it much faster, much more efficiently. I get a much better final finish and polish, reduce the amount of time I got to traumatize the tissue and the surrounding areas with rotary instrumentation, and I get really good aesthetics. So it's not just about survival, it's about lasting success. Let's show you a case. Here's on a typodont. I did this when I had shoulder surgery, so both arms weren't working well. I try to make good use of my time before I was able to come back and see patients. So I did an artificial prep on made a fake class 5 on a canine, on a typodont. And here's the axial view, just kind of made it kind of that average medium to large class 5 restoration. And now you can see I've come in here and I've created a bevel, but it's not your typical 45-degree bevel. You can see that it's very erratic, dips up and down. It's of various heights. So I use a fine diamond tip, like a needle tip diamond, that I make this very erratic EKG looking bevel. Here's another view of from top. You can see that it has different depths and different heights in projection. We'll talk about why I do that. Because it's a white background, it's a little hard to see, but I'm trying to show you from a few different angles. And here is the video of me placing it. So there's the Grandioso flow. And you can see that I'm placing, and I apologize for the kind of the shakiness. This is when my arms weren't quite working. I placed the single layer gingivally, which then I'll get an Explorer. And you can see how this is stiff enough that it's not running off the page. If it was runny, I don't have the right viscosity. I want something in the flow to heavy flow range. And I use an Explorer to drag it against a single wall, my gingival box, or my gingival wall, and I cure that. So now it's not locked into two walls, if you can imagine. So it's not pulling two walls together to test the adhesive layer. It's only shrinking against that adhesive layer, so there's zero shrinkage stress. Then I add my next layer, grab my Explorer, and add it to the previous layer. So if I'm taking this and treating it like a pie that's half the tooth, I'm basically adding back a slice of the pie one at a time until the pie is completely full again and the tooth looks untouched. So that we don't have to go super slow with this video, I'll fast forward, but you'll see that I basically am doing this over and over again. So a bigger lesion like this, I might take 4 increments to fill. And then finally, I'm going to look over the horizon, add a little bit of my final capping layer. Each layer below that has fully shrunk. So now there's no shrinkage stress built. And I'll use that final capping layer to drag into any areas that I perceive voids or up into my erratic bevel to the occlusal surface. And I'll look at that from multiple angles to make sure that I matched the height of contour of my tooth, the relative convexity that the tooth has. So instead of using a body composite that often leads to over addition and then very aggressive subtraction with the burr, my goal when I do this is to build a restoration that is darn near the final size of the tooth that requires very little finish and polish time. So here it is pre-polish. You can see that that height of contour makes that look like it's almost the next size we need. And I'll quickly go in there with some rotary fine carbides and I'll start to reduce it until it's the right shape and I'll give it the final finish. So here it is. And when I did this exercise, I did it on purpose, mismatching the shade. Whatever this ivorine tooth was, and I took a final black and white photo for you guys to see. It helps you see the value difference. Let's say this was an A1 colored ivorine tooth. I purposely chose an A4 colored composite. You can see how dark that is because you can see at the gingival aspect how you can clearly see the difference. Even though I didn't go up a shade, because of my erratic bevel, the way that the light is broken up, because there's fingers of composite that come in and project into this tooth, you can see that my incisal margin completely blends in. So even with a shade that's this badly mismatched, it almost blends in. So imagine if you get the shade even in the ballpark, these restorations just completely disappear. And a very quick finish and polish, and you're right where you need to be. So I'll end with one of these class 5 cases. This was actually my cousin who I hadn't seen for 7 or 8 years. They moved out of the area. When he came back to the office and I became his dentist again, I quickly found out that he had basically brushed away his teeth and gums. He had multiple grafting surgeries, and eventually it came to us restoring all these NCCLs, and I'll just take you through one of them. Here it is again, isolated with an Optrogate and an Isolite. There's my erratic bevel that you can see, and here's the final product. So literally with 3 additions of the Grandioso Flow and then a quick finish and polish, this is after the tooth has been under Isolite for a while, so it was desiccated. Very quickly you can see, and that's just the pre-finish, you can see how well that blends in. Those are the kind of margins that look the same, 3-year recall, 6-year recall. You're not going to find those significant stain and recurrent decay issues that you saw in those other photos. And this is what we were talking about. You want a composite that has this modulus of elasticity. This orange line indicates that of dentin, and you can see how the Grandioso has that very similar modulus so that it can move with the tooth under flex. Final kind of complementary products. How do we get such good finishes? I basically resorted to, after I do my pre-finish with carbides, I'm using one of 2 products, either from Ultradent, I'm using these Jiffy Naturals, or from Clinician's Choice, these ASAPs, which stand for All Surface Access Polishers. These are traditional silicone 2-step polishers. The difference is the flexibility. They have occlusal tips, and these wheels have these projections, kind of like car wash chamois, that really fold and bend around the nuances. So when you've created anatomy, you don't destroy it the way a very rigid cup or a point would. So hopefully that was some useful information. I'll close with this. I think anytime there's new products, new technology out there, specifically we're talking today about nano-filled composite materials, it's important for us to leverage that science and R&D and make sure our patients are getting the best that science has to offer. And I will again thank Voco and Viva for their support. And my email is there on the screen. I'm always happy to talk to and converse with participants that want to keep in touch with me afterwards. Otherwise, a big thank you, and I will take some questions now. Let's see. There are already some out here. Let's see. One is flowable will weaken the composite. I don't know if it's a question. Flowable will weaken the composite restoration, therefore shorten the longevity of the restoration and increase the chance of current caries. And that has absolutely been proven wrong in the literature. Flowable will never weaken a restoration as long as it's an appropriate flowable. Now, flowable brought up to the occlusal surface that should hold occlusion is a big no-no. We always want to have flowable at the gingival aspect. So when we're talking about modulating a flow with a heavier filled flowable, even then, we're not talking about putting that on cusp tips or marginal ridges or areas of hold occlusion. Underneath the base, a flowable is more than strong enough, an appropriate flowable, to have the compressive strength to become the backbone for the capping layer of the composite. In fact, some of the literature out there that I can share in a coming presentation actually shows that restorations that have a flowable base layer that has nothing to do with the occlusal actually show a reduced propensity for recurrent decay. What does the notch in the forceps do? So, okay, so good question. This is specific about the Triadent forceps. That notch helps you lock in the ring and pinch it closed. So it's not the end that you open the ring with to put it on the tooth, but if your ring has been spread apart multiple times and you feel like it's losing its ability to spread the tooth, by pinching it down with that notch, it's basically doubling as pliers. So you can compress the ring closed again to give it some more lifespan. Hopefully that was clear. What is the disadvantages using a dual cure composite that can be used on the occlusal as well? Very good question. I think, and they didn't use a specific brand name, but I'll share some that are out there. Things like Activa or Bulk Easy. These are composites that are dual cured in the sense that they're a base catalyst coming out of a dual mix tube, where they come out initially flowable and they start to go through a gel phase and then eventually set up. And they have the filler parameters to be able to act as similar to a capping composite, be able to withstand occlusion. The disadvantage to me is that they're decent products and I've tried them before. I don't dislike them, and on occasion I do use them. To me, the disadvantage is that I don't quite get the variance and the aesthetics that I want. I do a bit of aesthetic dentistry, and so I want to have my variances there. But the biggest disadvantage for me is the sculptability. With the body composite that I placed, I can sculpt and shape. With these, they kind of slump in like a flowable, and you can use an Explorer instrument to kind of drag them around. But really, eventually, when they gel and you hit them and light cure them, then you're obligated to go and carve in your anatomy with rotary instrumentations, which lead to concave or flat anatomy, and teeth, unfortunately, are bulbous and convex. So the big disadvantage there for me is my final outcome as far as shaping. Now, many dentists use only bulk flow for composite 2 restorations, pediatric teeth. What are your thoughts? Bulk fill flowables, I think, are great for the bottom half. I know that they're not designed to be the capping layer. I will always use a high quality capping composite for my final. Now, if a pediatric dentist says I'm working with a very tough child, moving target, I don't want to have things go in and out of the mouth multiple times, and they're using a bulk fill flowable on a tooth that's about to exfoliate in a year or so, I'm probably not going to find a huge amount of fault with that, but I think that kind of leads to bad habits. There are bulk fill body composites as well. So it's very easy to go in there with a bulk fill flowable, fill the bottom half, switch the compule to a bulk fill body composite, and fill the top half. So there's always a better solution to give the best possible outcome. Is it better to store products inside the fridge last longer? Yeah, that's a very good question. Almost all your adhesives and composites that come from manufacturers will have a shelf life on there, and they always will undershoot that, meaning the shelf life or the expiration there is based on a sales expiration. So generally, I know that they're okay to use past that expiration date. It's just that they can't sell it past that date and give you a decent window to use it. But you never want to push the envelope on that. If you store your products in the fridge, you know that you can use them right up to the last minute. If you have an office that can heat up over the weekends and the air conditioner is not running, I know sometimes in the summer in our area, I'll come into the office on the weekend, the air conditioner is off, and it might be 90 degrees or so. You don't want composites to heat up like that. And honestly, things kept in the fridge almost always help increase the shelf life. What is the company that makes a tooth separator? That was Triadent products. And they are sold, if you're talking about US, they are sold through Ultradent, and Dent Supply has a version as well. With the Class 5, is there prepping besides the feathering at the incisal? Well, that erratic bevel is the part that's prepping. Very good question. I probably neglected to mention this. When we're talking about the actual remaining dentin, whether that happened through acid erosion or abrasion, tooth rut abrasion. Sometimes you can tell by the look of the tooth whether it's more matted or shiny what the etiology was. But sometimes dentin there is sclerotic. I don't want to waste additional dentin, but I will always score that dentin, meaning I'll put a fine rounded tip diamond burr on there. Some folks have an air abrasion unit chairside. That's also not a bad way to go, where I'm not materially taking away tooth. The prep doesn't look any bigger there. The only thing you see is the erratic bevel, but I will at a microscopic layer score that because I want to make sure I'm bonding to clean, new, unaffected dentin. So that's a very good question. I'm glad you asked it. And yes, it's the equivalent of me basically rubbing sandpaper on that dentin. It was the same reason why I would always sand the deck before I put new varnish on it. It's always going to lead to a better final outcome. All right, that looks like the end of the questions. It was awesome spending time with everybody. Thank you again to Viva and Voco, and I look forward to the next project. Bye now.